Welcome, students, to part 95 of our masterclass. If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. In part 94, we conquered the surgical side of things with skin debridement and reconstructive surgery. But today, we're shifting gears for a really massive, high-yield explainer. We are diving deep into the advanced medical DRG logic for major diagnostic category 10. We're talking acute endocrine emergencies, severe metabolic derangements, and nutritional crises. This is an area where precision is literally everything, and trust me, payer audits are relentless here. Here is our roadmap for today. 1. An MSDRG architecture recap. 2. Diabetes and metabolic coding. 3. Malnutrition indicators. And 4. CDI and audit defense. Section 1. MSDRG architecture recap. Before we get into the weeds with specific disease codes, we just need to quickly anchor ourselves in the core logic of the system. Remember our fundamental formula, right? A DRG is a statistical system used to classify any inpatient stay into groups that are expected to have similar resource consumption and clinical characteristics. Simply put, clinical similarity plus resource similarity equals one payment group. This is the absolute bedrock of the inpatient prospective payment system used by Medicare. The MSDRG grouper looks at your principal diagnosis to figure out the major diagnostic category. And then it splits those cases based on whether a major operating room procedure was actually performed. The DRG system uses a triplet structure, which totally dictates your final payment tier. You've got the base level without complications or comorbidities, the middle tier with a CC, and then that highest tier with an MCC, or major complication and comorbidity. Your ability to accurately pluck these CCs and MCCs straight from the clinical documentation is crucial. Missing an MCC like acute respiratory failure or severe sepsis, that means a massive loss in reimbursement for the heavy resources your hospital actually utilized to save that patient. Moving right along to Section 2, Diabetes and Metabolic Coding. Let's look at the exact ICD-10-CM coding mechanics for these conditions, because this area is honestly a minefield of coding traps. When it comes to coding diabetes, you absolutely cannot just slap a generic code on the chart and call it a day. You have to first identify the exact type using categories E08 through E13. For instance, E10 is type 1, E11 is type 2, and you also have secondary or post-pancreatectomy rules to think about. But here is the critical part. You must capture the manifestation chain by specifying complications. Does the patient have diabetic neuropathy, nephropathy, retinopathy? If the attending documents type 2 diabetes with chronic kidney disease stage 3, you need code E1122 for the diabetic kidney disease plus the N18.32 code for that specific CKD stage. It's like putting together a very specific puzzle. Think about the contrast between vague and specific documentation, which perfectly illustrates why clinical documentation improvement, or CDI, is such a game changer. If a physician just jots down history of diabetes or diabetes without complications, you end up with E11.9. And guess what? That yields absolutely zero additional DRG weight. It's not a CC. It's not an MCC. But if they specifically document the acuity, say, type 2 DM with ketoacidosis, you get code E11.10. And boom, diabetic ketoacidosis triggers a massive MCC. When you look at the raw numbers, the impact is undeniable. Imagine a scenario where our patient has a principal diagnosis of sepsis. By capturing E11.10 for type 2 diabetes with ketoacidosis as a secondary diagnosis, it acts as an MCC. The relative weight essentially doubles, jumping from 0.86 all the way up to a massive 1.9. That is the real-world power of specific documentation. Now, another metabolic trap involves severe electrolyte imbalances. Say a patient is documented with both hyponatremia and SIADH. That's the syndrome of inappropriate antidiuretic hormone secretion. How do you code it? Well, remember your ICD-10-CM conventions. These two fall under an excludes one note. That means these two conditions cannot be coded together unless their etiologies are totally, completely different. In this specific case, you must solely code the SIADH. Knowing these little conventions is exactly what prevents audit failures down the line. Section 3, Malnutrition Indicators. Let's transition over to nutritional failure, which is another major diagnostic category that constantly faces aggressive payer audits. Malnutrition is highly, highly scrutinized. If a patient is admitted with a vague symptom like generalized weakness, it is your job to put on your detective hat and look for ASPIN or ESPIN clinical criteria. Are there notes about a reduced energy intake, a loss of subcutaneous fat, muscle mass loss, or sarcopenia? What about a measurable decrease in hand grip strength? If these indicators are hanging out in the progress notes or the nursing assessments, but the diagnosis isn't explicitly stated by the doctor, you've got a missing link that needs fixing. So once malnutrition is identified or suspected based on those clinical indicators, you have to query the physician for the exact severity. Why? Because your DRG impact hinges entirely on that one word. Mild or moderate malnutrition, which is code E44.0, acts as a standard CC. But severe protein-calorie malnutrition, code E43, that acts as a major complication, an MCC. If the doctor just writes malnutrition, you leave that MCC weight sitting right on the table. And that brings us perfectly to Section 4, CDI and audit defense. Let's talk about how we actually defend these high-yield codes against those aggressive payer denials. CDI is a tight, collaborative process between coders and physicians. It's your frontline defense mechanism to ensure every single diagnosis is completely and accurately supported by the clinical evidence in the chart. The whole goal is to accurately reflect the patient's severity of illness and risk of mortality. If the chart says one thing but the clinical indicators say another, you're looking at an audit waiting to happen. This is where seamlessly integrating registered dietitian assessments and getting physician co-signatures becomes your absolute best defense. You have to initiate a formal CDI query whenever the documentation triggers certain red flags. If a diagnosis is ambiguous, like they say history of stroke instead of specifying the exact type of infarction, you query. If severity is missing, like documenting CHF without specifying if it's acute on chronic systolic, you query. Or if two progress notes are conflicting, like one says UTI and the other says pyelonephritis, you absolutely have to clear that up before the bill drops. But here's the catch, and it's a big one. When you formulate these queries, you must be compliant. You absolutely cannot lead the physician. Asking, Dr. Smith, the patient's hemoglobin is 6.2. Can we code this as acute blood loss anemia? Is incredibly non-compliant. You're literally putting the answer in their mouth. Instead, craft non-leading questions like, Dr. Smith, the patient's hemoglobin is 6.2 following surgery. Can you clarify if the anemia is acute, chronic, or due to another cause? You must give them clinical options without biasing them toward that high-paying diagnosis. You also have to carefully track those present on admission or POA indicators. Let's talk about a vital compliance rule. Even if you beautifully document a severe MCC like an acute deep vein thrombosis, if it developed 2 days after admission, the POA flag is N for no. CMS considers this a hospital-acquired condition, or HAC, and under the Deficit Reduction Act policy, an HAC cannot be used to increase your DRG payment. In fact, the hospital will be subject to a quality review and a non-payment penalty for that condition. Ultimately, surviving a clinical validation audit means you have to integrate objective data directly into your CDI defense. Payer auditors are gonna look at the lab results, for sure. Whether it's elevated WBCs in a urinalysis or specific markers for diabetic ketoacidosis, like a pH below 735 or an anion gap greater than 12, you must ensure the physician's diagnosis is 100% clinically justified by the raw, hard data in the chart. So, what does this all mean? Mastering the grouping logic for complex metabolic diseases, nailing down the exact severity of malnutrition, and utilizing strictly compliant, non-leading queries is what will protect your facility's revenue and compliance standing. Precision is absolutely everything. Join us for Part 96, where we're going to tackle the surgical side of this category, exploring endocrine, bariatric, and metabolic surgery. Before you go, ask yourself this. Is your facility leaving thousands of dollars on the table simply because a physician wrote malnutrition instead of severe malnutrition? Think about it. And as always, if you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. Keep learning, keep querying, and I'll see you in the next explainer.